Bismillahirrahmanirrahim. In the name of Allah, we will discuss today how to do proper sample collection. Laboratory helps in most of clinical situations. Laboratory tests pass through many steps. An error in any point will lead to wrong lab test results. What are the sources of error in laboratory test results? The sources of error in laboratory test results are divided into pre-analytical, analytical, and post-analytical. The main source of these errors are pre-analyticals. As you can see in this figure, it may reach up to 68.2% of whole laboratory test errors. Our scope today is how to minimize pre-analytical errors. Sources of pre-analytical errors may come from improper order, incorrect identification, improper patient preparation, incorrect sample collection, insufficient sample, improper sample handling and transport. The first cause of pre-analytical error is improper order. Common order problems in KKH are stat improper order due to ordering too many tests, stat request in non-indicated situations, non-indicated tests, discrepancy between request form and WASE's order. This item has been solved after full implementation of WASE's in the hospital. No clinical data or improper clinical data entry in request, repetition within short interval, ordering too many tests with no clinical indication. This is a list of stat tests in KKH lab according to the policy. Please read the policy regarding stat tests. The next pre-analytical error is incorrect identification. Request should be filled with patient name, patient file number, ward, bed number, date and time of request, clinical data of current patient condition, physician signature, and stamp. All these items have been solved by making WASE's order, except number 6, which is still not solved yet. Tube also should be labeled with patient name, patient file number, and these items also have been solved by barcode sticker. Failing to properly identify patient is a potentially fatal specimen collection error. The next pre-analytical error is improper patient preparation. Commonest pre-analytical preparations are fasting, which is preferred for all tests to avoid marked lipemia. It's a must in fasting blood glucose and glucose tolerance tests. Also, it's a must in lipid profile, especially triglycerides. Errors related to medications, as to stop antibiotics before cultures if possible. Time of performing the test is important in some situations as serum cortisol level and some female hormones. Here are examples of lipemic samples. Such samples cannot be processed in our hospital. 12 hours fasting can prevent lipemia in most patients. The next pre-analytical error is incorrect sample collection. Hemolysis is the commonest cause to reject samples in KKH laboratory. Causes of hemolysis are drawing through vascular access devices, prolonged tourniquet application, alcohol left on the skin at time of extraction, excessive pulling pressure on the blinger of the syringe, inappropriate blood to anticoagulant ratio, milking the site of capillary puncture, using narrow pore needle, evacuation into tube with syringe needle, excessive and rough inversion of tubes. These samples show hemolysis, which is expelling out of RBC's contents into plasma or serum. Hemolysis affects many analytes in the form of increase or decrease of the results. Samples must be extracted in its specific tubes. Here are examples of tubes types in relation to sample required. For more details, please read the policy. The next pre-analytical error is insufficient sample. Tube must be filled till the mark. Problems of insufficient samples are Dilutional effect occurs if using anticoagulant tubes. Sample may not be enough to do all required tests. The picture to the left shows empty tube which was given to our lab reception. Another example of empty tube was given to our lab reception. The next pre-analytical error is due to improper sample handling and transport. Container must be closed well. Sample is sent immediately to lab. Special precautions in some situations as ice pack container for some tests like ammonia, lactate, certain hormone tests, blood gas determinations. This is an example of leaking container. Such samples are rejected. Avoid delayed sample delivery. Clotted sample is one of the common causes of rejected samples in KKH lab. Samples withdrawn with anticoagulant must be immediately mixed well at time of withdrawal. Avoid vigorous shaking of the sample. Mixing is made by just inversion of the tube 5 to 7 times without vigorous inversion, just wrist joint level movement. The next section is safe and proper blood sample withdrawal. What are the requirements for proper sample collection? Here are examples of items mostly required. Vacuotainer system needle, tourniquet, better to use disposable one, holder for needle and tube, tubes according to desired sample, alcohol swab, adhesion tab, and piece of cotton. Blood sample tubes are selected according to type of sample required. Yellow arrows here point to commonly used tubes in our hospital. Try to avoid classic syringe in sample withdrawal. Using closed vacuotainer system prevents sample contamination. Choose the suitable needle size for your patient. Bear in your mind that this rubber piece covers the needle that pierces the stopper of the tube. It's better to use phlebotomy collection tray or mobile phlebotomy station. Steps for sample collection. Do hand wash as recommended by Infection Control Department. Prepare withdrawal kit. Put the patient in proper position in phlebotomy station unless patient is bedridden. Wear gloves. Confirm patient data. Identify patient correctly. Remember that this is the most important step. Use broad tourniquet. It's better to use disposable one. Apply tourniquet properly in a way that allows easy removal. Avoid prolonged venous occlusion by tourniquet. It affects the results of many analytes. You should know the anatomy of withdrawal site to avoid unnecessary injury of important structures. Avoid palmar surface of wrist joint. Apply antiseptic in a spiral direction from inward outwards. Wait till antiseptic dry completely. Assemble the kit. The contact angle should be 30 degrees to skin with bevel up. Don't introduce the needle in open angle to the skin, as the needle may pierce the vein causing hematoma. Use proper needle size. Narrow bore needle is a cause of hemolysis. Aspirate blood in tubes in proper order of draw. Fill the tubes till the mark. Remove the needle and apply piece of sterile cotton. Secure the needle. Discard the needle in sharp container. Apply gauze in adhesion tab to withdrawal site. Label the tube correctly. Prepare for sample transportation in biohazard bag with the request if needed. Take off the gloves and discard in yellow container. Order of draw. First start by sterile blood culture tubes or vials, serum tubes, then blue stopper tubes, then green stopper tubes, then lavender stopper tubes, and lastly gray top tubes. The next video summarizes safe and proper sample withdrawal. Here are requirements. Apply tourniquet, should be white and disposable if possible. Apply antiseptic. Assemble kits. Be sure that bevel is up. Make contact angle to skin about 30 degrees. Fill the tubes in proper order of draw. Remove the tourniquet. Remove the needle and apply piece of cotton to withdrawal side. Secure the needle. Discard the needle in sharp container. Then we move to next chapter, which is collection from venous access devices. Blood sample collection may be drawn from peripheral venous access devices only at the time of insertion. Blood samples should not be collected from indwelling, peripheral or midline catheters. Central venous catheters can be used for administration of fluids, drugs, blood products, and nutritional solutions and to obtain blood. Four main types of CVCs are used. Non-tunnel, non-cuffed central venous catheter. When using multi-lumen catheters, the proximal lumen is the preferred lumen. Tunneled, cuffed CVCs may be single, double, or triple lumen. Implanted port. Peripherally inserted central catheters, PICC. The advantage of PICC is that it has few risks and causes minimal discomfort to the patient. A disadvantage of blood collection from a PICC is that the catheter walls are easily collapsed. Blood sample collection. Stop IV fluids administration through CVC for 5 minutes before collecting the blood sample. Syringes larger than 20 ml should not be used. The first 5 ml of blood must be discarded or conserved, and a new syringe must be used to collect sample. Drawing coagulation tests from a venous catheter is not recommended, but if this is necessary, they should be collected after 20 ml of blood has been discarded or used for other tests. The order of tube fill. First syringe is discarded or conserved. Second syringe for blood cultures. Third syringe for anticoagulated tubes, light blue, then lavender, then green, and lastly green. Clotted tubes, red and serum separator tubes. If blood cultures are not ordered, the coagulation tests can be collected with a new syringe after the other samples have been collected using the order shown earlier. The source of the sample should be noted in the OSS request form. When blood is collected from a central venous access device, blood should not be left in the syringe while extensive flushing of the CVAD is performed. Before starting the procedure, ensure that all requirements are available. Step number 1, verify patient identity using two identifiers. Explain the procedure and position the patient in a supine position. Assemble the supplies, wash hands and wear sterile gloves, maintain aseptic technique throughout the procedure. Discontinue administration of all infusates. In multi-lumen catheters, the proximal lumen is the preferred lumen to obtain the sample. Attach a 10 ml pre-filled saline syringe to a 3-way stopcock. Prime the stopcock with saline. Disinfect injection cap with alcohol wipe using vigorous friction. Scrub on the top and in the grooves for 15 seconds, which should be increased to 30 seconds for blood cultures. Attach stopcock with syringe to injection cap. Unclamp lumen and flush with remainder of saline. If the only lumen available to draw blood has total parenteral nutrition infusing, flush with 18 to 19 ml of saline. Clamp lumen and or turn stopcock to off position to syringe port. Remove syringe and apply a new empty syringe to the same port. Turn stopcock to off position to the unaccessed port. Unclamp lumen. Aspirate 10 ml of blood into the empty syringe. Leave attached. Attach another empty syringe to the second stopcock port. Turn stopcock to off position to the blood-filled syringe. Draw blood sample into the empty syringe. Reinfuse blood from previously filled syringe. Remove stopcock and syringe. Cleanse injection cap with alcohol pad. Attach pre-filled saline syringe and flush with 18 to 19 ml of saline. If IV infusion has been discontinued, remove protective cap from tubing and reconnect infusion tubing. Resume all infusions. Connect a blood transfer device to the collection syringe and insert into evacuated tubes. Allow each tube to fill completely and according to the order of fill. Label each tube appropriately and confirm with patient data. Prepare sample and requisition for transport to the laboratory. Dispose of used supplies in biohazard container. Remove gloves, wash hands, and thank the patient. If there is any uncertainty about the integrity of the blood to be reinfused, the blood must be discarded. Potential test error can be due to hemolysis caused by air leaks and incomplete flushing of the collection site causing contamination or dilution of the sample. The next and the last chapter is blood collection from an implanted port. Ensure all requirements are available before starting the procedure. Identify patient using two identifiers. Assemble equipments. Palpate the shoulder area to identify the septum of the access port. Prepare the area with chlorhexidine gluconate applicator. If using alcohol and iodine pads, prep in a circular motion from within to outwards. Allow to dry completely. Connect the non-cooling needle tubing on the end of one 10 ml saline flushing syringe and prime the needle with saline until it's expelled. Locate the septum of the port with the non-dominant hand. Firmly anchor the port between the thumb and the forefinger. Puncture the skin and insert the needle at a 90-degree angle into the septum using firm pressure. Advance the needle until the needle touches the back wall of the port. Inject 1 to 2 ml of saline. Observe the area. If swelling occurs, reposition the needle in the port without withdrawing it from the skin. If there is not swelling, aspirate for blood return. If blood return is observed, continue to flush with saline. Using the same syringe, aspirate 10 ml of blood and discard or conserve it. Attach the syringe to the needle tubing and collect the blood necessary for ordering laboratory tests. Dispense the blood into the appropriate blood sample tubes. Flush the needle and the port with 10 ml of saline. Change syringes and flush with 3 ml of heparinized saline or follow hospital policy. Remove the needle and apply a sterile dressing over the site. Label samples appropriately. Confirm label with patient. Remove gloves and wash hands. Prepare sample and requisition for transport to the laboratory. Dispose of used supplies. Thank the patient. Remember, proper sample withdrawal is the cornerstone to get correct lab answer for a clinical question. All should cooperate together to reach our target.